Hello everyone, in this video now we'll study about immune thrombocytopenic purpura. As the name itself says, there is thrombocytopenia, decreased platelets, as a result of which purpura is present. We'll study what are its causes, clinical features, management, and we'll also see how the questions will be asked in the MCQ exams, what will be the case history and all. So now first let's see what is the pathology in this ITP. So why it is caused. Here there will be antibodies which are produced against GP2B3A receptors which are present on the platelets. So I'll stress upon this, that is GP2B3A, because there are many receptors on the platelets and there are many other diseases which is caused because of the problem to the different receptors on the platelets. But here in case of ITP, it is the GP2B3A receptors on the platelets which are being attacked by the antibodies. These platelets which are attacked by these antibodies will be engulfed by the macrophages, and these macrophages carry them to the spleen for destruction, as a result of which more and more platelets which is attacked by these antibodies will be destroyed by the spleen. As a result, there will be low platelets. So now let me just explain you how the whenever there is an injury to the endothelium, how this clot formation occurs. So how are the different receptors of the platelets involved in the formation, and hence you can understand easily where the exact pathology occurs in the ITP. So whenever there is an injury, there will be damage to the endothelial cells. So the first response for any hemostasis is the vasoconstriction. So later, the von Willebrand factor will be released by the endothelium and the alpha granules of the platelets. Also, the GP1B receptor will be present on the platelets. So this GP1B receptor on the platelets, as you can see there, which I have written in red color, binds to the von Willebrand factor, and these two together will bind to the exposed collagen in the subendothelium. Collagen and the subendothelium. So this process, what is this GP1B von Willebrand factor binding to the collagen, this will release the ADP. This ADP binds to another receptor called P2Y12 receptor, which is present on the platelets. This process, that is binding of ADP to the P2Y12 receptors, as you can see in the image which is present down, will cause expression of GP2B3A receptors. Until this process occurs, the GP2B3A receptors will not be expressed on the platelets. This expressed GP2B3A receptor, which I have again written in the red color in the image which is present down, will bind to fibrinogen and can also bind to the GP2B3A receptor on the other platelets. As a result, there will be platelet aggregation and the fibrinogen accumulation. Hence, clot which is stable fibrin clot will be formed. This is how a clot formation occurs whenever there is an injury or the endothelial injury occurs and the hemostasis occurs. Now here in ITP, this GP2B3A receptor is the one which is being affected by the antibodies. So this affected platelet will be carried by macrophages to the spleen and it will be destroyed there. This is how thrombocytopenia is occurring. So it is an extravascular hemolysis, that is hemolysis is occurring outside the vessel. I hope you know the difference between intra and extravascular hemolysis. In case you don't know, let me just say it briefly. In case of intravascular hemolysis, where the hemolysis is occurring inside the vessel, there will be features like hemoglobinuria, that is passing of blood in the urine, because there is hemolysis is occurring inside the vessel. As a result, gallstone formation will also occur. Whereas in case of extravascular hemolysis, where the hemolysis is occurring outside the vessel, usually it will be associated with splenomegaly, but hemoglobinuria will not be there. Here, in contrary to the usual case what we see in extravascular hemolysis, that is the splenomegaly, but here, though it is an extravascular hemolysis, here there is no enlargement of the liver and spleen. That is the another point you should note. And the next very important thing is, here the RBCs and WBCs are normal. Why should RBCs and WBCs decrease here? What is the pathology here? Antibodies against the receptors of the platelets, as a result of which platelets are being destroyed in the spleen. There is no involvement of RBCs. There is no destruction of any RBCs or WBCs here. Hence, in the peripheral smear, you can see the normal RBCs and the normal total leukocyte count. This normal RBCs is very important because this differentiates between the TTP, that is thrombotic thrombocytopenic purpura. I'll explain it to you detail in the other video, but for here, just remember that in TTP, RBC counts will also be decreased along with the decreased platelet count. Coming to the cause, in children it is usually idiopathic. In adults, most commonly it is due to some autoimmune disorders like SLE, which is most common. Other like HIV, lymphoma can also be present. Now coming to the clinical features. ITP and TTP, so these are the platelet disorder. So once I say platelet disorder, you should be able to say what is the basic clinical feature the patient will be having. It is, yes, it is epistaxis, purpura and bleeding gums. So if in case you don't know, let me say it again. Any platelet disorders like ITP, TTP and many others will have clinical features like epistaxis, purpura and bleeding gums, whereas the coagulation disorders like hemophilia will have hemarthrosis or bleeding gums. This clinical feature is itself the basic thing to differentiate between the coagulation disorder and the platelet disorder in terms of the symptoms, in terms of the clinical feature. Here in case of ITP, the bleeding can be very severe, like GI bleeding can be present. In women, dysfunctional uterine bleeding, DUB can be present. Whereas specifically seeing, there is slightly varied presentation in children and adults. Let's see what it is. In case of children, there will be usually the history of viral fever since 2 to 3 weeks, and the platelet count may go less than 20,000 also. But the important thing to note here is in nearly 80% of the children without any treatment, the spontaneous remission will occur. This is a very important point to be remembered. In case of adults, it is insidious in onset. Usually, there will be no history of viral fever. The platelet count will be usually between 20 to 80k, and it is very rare for the platelet to go below 20k in contrary to that of children, where the platelet counts going below 20,000 is usually normal. Another important thing is, as I said, in children, in 80% of them, the spontaneous remission occur, which is a very good thing. But here in adults, the spontaneous remission doesn't occur. So that is, it doesn't go away on its own. We have to provide the patient with the treatment. Now see what are the findings in the investigations. So we have to do CBC, peripheral blood smear. So what you can see is the isolated thrombocytopenia and the giant platelets. Isolated thrombocytopenia, as I said, only the platelet will be decreased, whereas the RBC and the total leukocyte count will be normal. In bone marrow aspirate, you can see increased megakaryocytes. In USG, as I said, though it's an extravascular hemolysis, the spleen size will be normal. But the most sensitive investigation is looking for the exact pathology. What's the pathology in ITP? It is antibody against GP2B3 receptors. Hence, finding out whether this antibodies against GP2B3 receptors are present or not is a sensitive investigation which you can do through many measures like ELISA. So now, how do we manage? If the platelet count is greater than 50,000 and there is no bleeding, so no treatment is required. If the platelet count is between 20,000 to 50,000, we have to give the patient with steroids like prednisolone. If the platelet count is less than 20,000 or very severe bleeding is present, then IV anti-D immunoglobulins has to be given only in case of Rh positive. In recurrent cases, that is, you have treated the patient, but the patient is presenting with the same complaint, same features again and again despite giving them with the treatment, then the only option is the splenectomy. How does splenectomy help? This antibody attack platelets will be attacked by macrophages and they will be destroyed in the spleen. When this destruction site, the spleen itself is removed, then the platelets will not be destroyed. So this is the idea behind this. As you know, before splenectomy, what is the very important thing you have to do before the surgery? Yes, you have to vaccinate the individual against the capsulated organisms like Haemophilus influenza, meningococcus and pneumococcus. So now if the platelet count is very low, like less than 5000, we have to do platelet transfusion in conjunction with the IV immunoglobulins. Always remember, platelet transfusion is not done alone. It has to be done along with IV immunoglobulins. So platelet count below 20,000, it is IV immunoglobulins. Platelet count less than 5000, IV immunoglobulins along with it platelet transfusion can be done. But more than 5000, platelet transfusion is usually not recommended. So now all these measures fail. So you had started the patient on steroids or immunoglobulins according to the patient conditions. It doesn't work. You do splenectomy. It also doesn't work. Then what will you do? So there are thrombopoietin agonists similar to the erythropoietin agonist, which will stimulate erythropoietins. Here thrombopoietin agonist will stimulate the platelet production. It is like romiplostim or L-thrombopag. Romiplostim is usually given subcutaneously, whereas L-thrombopag is given oral. The other one is the anti-CD20, which is rituximab, can also be given. So now we'll see a case scenario, how the question will be asked in your NEET PG examination and how you have to tackle them and rule out the options. So now here some history is given and some options like ITP, TTP, hemophilia and all are given. So for this, you have to know what are the coagulation disorders and which are the platelet disorders. Here you know ITP and TTP are the platelet disorders and hemophilia is the coagulation disorder. I'll be making another video as to what are the different coagulation disorder, platelet disorder and what are the pathologies involved. So stay tuned with the channel. Now here how will you differentiate between the coagulation and the platelet disorder? As I already said, these words like purpura, petechiae and bleeding gums typically indicate it is a platelet disorder. Whereas if there is a word like hemorrhagosis or bleeding into the joints, or an image showing swollen joints and saying this bleeding into these joints or hemorrhagosis is present, then you can go for coagulation disorders like hemophilia. Whereas here it is purpura, petechiae and bleeding gums, which typically indicates it is a platelet disorder. So hemophilia is ruled out. Other important thing with which you can rule out is by seeing the investigation. Here the BT is prolonged, whereas PT APTT is normal. So as a general rule, BT will be normal, whereas PT APTT will be affected in case of coagulation disorder, whereas BT will be prolonged and PT APTT will be normal in case of platelet disorder. So now here it is a platelet disorder. So how to differentiate between ITP and TTP now? Straight away go to the RBCs, what they have given. So here they have mentioned normal peripheral smear. So whenever the RBCs are normal, it is a ITP, whereas in case of TTP, the RBCs will also be decreased along with the platelets. So now you can come to the conclusion that it is an ITP. So this is how you have to rule out the options. So next, the other way the question can be asked is they can give you a case scenario, and now based upon the hints they have given, you have come to the conclusion that it is an ITP. Then they will ask you the platelet count is some 30,000. What will be the answer? It is IV prednisolone. The question says some 15,000. What will be your answer? It is IV immunoglobulins. The question mentions the treatment has been given and the case has recurred. What will be your answer? In the option, you have to choose splenectomy if it is present. I'll make a separate video on all the MCQ questions regarding this topic. So for this video, that's it. And if you like this video, please like and subscribe to the channel because I'll be uploading many other videos also on various different topics of medicine. Thank you so much.